I would like to welcome you to the 9th Marialuisa Ferrari Lectureship for Life. As you can see from the number, this was instituted in the year 2000 by the Ferrari family in honor of Marialuisa, who was the first wife of Professor Mauro Ferrari. The lectureship is focusing on the quality of life of patients, mostly with cancer. And it has been well attended, and we had the wonderful opportunity to have incredible awardee to this lectureship. I'm going to ask Professor Mauro Ferrari to come and give the introduction. Thank you very much.
It is now a privilege like no other to introduce Professor Veronesi. Of course, every year with the great people that have come to accept the awards, we want, what are we going to do next year to top this? Now I'm really terrified what we're going to be doing next year, because after Veronesi, I don't know what we can come up with. I hope the Pope is not booked for the date that we have in mind. President Obama, I never dreamt of the day that I could say these three names consecutively. President Obama, Governor Arnold Schwarzenegger, and Senator Dr. Umberto Veronesi, but all three of you, you may not know this, but all three of you are here in town today in Columbus, Ohio for three different events. President Obama is speaking, I just saw him on CNN, to the Police Academy. Of course, Arnold Schwarzenegger has his annual bodybuilding extravaganza here, and we have you here with us. And I'm glad that you get to see, after the experience yesterday, we were coming in with all the bodybuilders on the plane. I'm glad that you can see that people in Columbus are actually pretty normal, because you may have gotten the wrong impression here. Now, what I cannot identify, I'm not smart enough to find too many common traits between these three gentlemen, but certainly one thing that they do have in common is great leadership. And in the words of President Obama, actually, leadership is the bringing of hope. It's impossible to match what Professor Veronesi has done to bring hope to cancer patients in Italy and worldwide, in Europe and worldwide. And let me summarize very quickly. So he's a medical doctor, he's from Italy of all places. I gotta say this, he was born in 1925, I hope it's okay, it's in your resume. He got on a plane just for this. He came in last night, he's giving the award and he's flying right back. He had an engagement in Phoenix that he was going to pair up with this, but you know, that fell through because of his engagements in the Senate. He said, I gotta go to Columbus. Thank you, Dottore. You are privileging and honoring us beyond any merits. That's fantastic. So, Dr. Veronesi is a breast cancer surgeon. One of his great accomplishments you've all heard of, and he will tell you in greater detail about, breast cancer patients. Anybody ever heard the word lumpectomy? Lumpectomy comes from Professor Veronesi, quadrantectomia as it is called in Italian sometimes. It comes from his insight and his developments, and through his pioneering work, came across the ocean and went all over the world. So the impact that he has had, I think, is literally second to none in the field of breast cancer. But Dr. Veronesi is not only a visionary clinician, he is really a leader in multiple senses of the word. He's a political leader. He's currently a senator. He was the Minister of Health in Italy. He is a professional leader. He was the director of Italian National Cancer Institute. He was the director, the founding director of the European Institute of Oncology, which he currently still is the scientific director of. He is the founder of the organizations of European cancer associations, and the list goes on and goes on. Publication record second to none, awards from anybody that you can think of, and I don't want to take any more of your time to go through all these details, but you've captured the essence. I hope that I was able to convey some glimmers of the essence of this absolutely extraordinary gentleman. And so Professor Veronesi, father of 7, grandfather of 15, we are delighted to have you here in this great family.
Thank you. Thank you, Mauro, for very kind words of introduction. It's really a great pleasure and a privilege to be awarded the Marialuisa Ferrari Award for Life. Let me say how deeply honored I feel to be for this recognition for a long life, all devoted to the fight against breast cancer. I was particularly pleased to read the motivation of this prize, of this award, and the objectives of the lectures, which say that the lectures are dedicated to make doctors, nurses, community leaders more and more educated in cancer palliation, or in palliation, pain palliation, or in palliative care, as we say. And this is very important because it's been for all my life one of the main objectives. Today I will not speak on palliation in strict terms, but will speak about palliation in with a wider aspect. Meaning that we consider palliation reducing the women's sufferance by improving their quality of life. So it's a wider, in a wider sense, it's still a palliation. I think everybody may know that in the 60 up to the 70, women with breast cancer were treated according to an old rule, which you see here. A woman should receive the maximum tolerable treatment. This was the rule, this was the standard. So mutilating surgery, mastectomies, extended mastectomies, removing also the muscle, pectoralis muscles, all the lymph nodes. Then radiotherapy, extensive burning radiotherapy on all the chest. Then after that, very often oophorectomy, sometimes adrenalectomy, sometimes hypophysectomy. This was the condition of the poor women when they survived the disease and survived the treatment. So I think I thought that this type of approach was unacceptable. And I suggested to the surgical and the oncological community a totally different approach. I tried to introduce the opposite of the first one. No more maximum tolerable treatment, but minimum effective treatment. Trying to identify a treatment which would be effective, with the same efficacy as the previous one, but with less aggressiveness. This was my task. Of course, it's very difficult to reach these new positions from this, let's say, the scientific point of view, and statistical trials, statistical evaluation of randomized trials are needed. So I launched a program which started in 1969 just to have a number of progressive continuous, let's say, clinical trials, randomized trials, to identify new types of new procedures. First of all, for the conservation of the breast, then conservation of axillary nodes, then partial intraoperative radiotherapy. This was a long program, which, however, at the end, everybody in the world recognized was effective. This is the very historical moment. In 1969, I was able to convince the chairman of this very important meeting, WHO meeting, where most of the more important experts in breast cancer were together to put in the agenda an item dealing with breast conservation, a possible clinical trial to identify or to compare the radical mastectomy with a breast-conserving surgery. Of course, as you can imagine, my proposal was immediately rejected by the group, because at that time mastectomy was a dogma, and dogma cannot be discussed. It was rejected with great insistence, but fortunately, thanks to the friendship of a few American surgeons, I might say, after 3 days of long discussion, I was able to make this procedure, this option, introduced as a third possibility in a randomized trial, which was under discussion. After discussion of price of a Veronesi paper and more conservative management of breast cancer, it was decided the method of treatment consisting in a local excision of the tumor plus axial dissection should be added as a fourth option to this clinical trial. The clinical trial, which was in progress, was under discussion, was the comparison between Holstead radical mastectomy and modified radical mastectomy. These were because modified radical mastectomy, saving the muscles, were still not accepted, was still under discussion. So you can imagine the shock of the group when they proposed just a local excision of the tumor. Which type of surgery? Of course, as soon as I had this approval of WHO in my hands, in my pocket, I came back to Milan and decided to proceed. But what do we mean for breast conserving surgery? What is the procedure? What's the technique? And we started with a principle that we must, of course, conserve the breast, save the breast, but avoid local recurrence as much as possible. This was the risk, and this was the reason why we started our own procedure. Our own procedure was a lobectomy. You know, in the breast there are 12 lobes, and each lobe has its own identity. It's a ductal tree, the ducts are there, and when a tumor is born inside the lobe for a long time, it remains in the lobe. It may spread through the ducts in the intraepithelial spreading, but only after a certain dimension may invade other lobes. So my idea was to remove the lobe, to have a lobectomy. But of course, when I spoke about lobectomy to my friend, with my surgeon friends, they didn't understand, because the lobectomy is not an anatomical entity, it's a functional entity. So I decided to use the name, which I don't like very much, but quadrantectomy, to remove a quadrant. This was easier for the surgeons to understand what I meant. And this was one of the first operations which I did. You see, the breast is saved, is in a good fashion, in a good appearance, with a long scar. Today we have more conservative, because to remove all the lobe, you have to start from the nipple to the periphery. And so this was the principle, and we made a randomized trial. We randomized 700 women between two groups, one receiving Holstead mastectomy, the other group receiving quadrantectomy, axial resection, and radiotherapy. In 1981, 10 years later, we were able to publish on New England Journal of Medicine our results, which were very favorable. There was no difference in recurrences, in survival between the two groups. This was a very important moment. But I would say that likely this result would have passed not really observed by the medical community, unless the day after the New York Times put in the front page on 4 columns our study. And this was really the beginning of the movement, because most of the American women, the very women groups, women societies, decided to start a movement to ask their surgeons to reconsider the mastectomy and to consider the possibility to save the breast. So everything started. This is my study, which was revised after 30 years. You see wholesale mastectomy, quadrantectomy, radiotherapy, no difference. After so many years, absolutely no difference in survival. And what is important is that I invented the dosage of radiotherapy, 50 gray plus 10 gray in 1969. And today is still the same dosage is given to the women after breast conservation, identical, nothing was changed. Then, of course, we asked ourselves, are we sure that we need such an extensive quadrantectomy? Would be not enough to have a smaller operation. In that period, the beneficiary launched the lumpectomy. So we did a second randomized trial, comparing the quadrantectomy, the quadrantectomy with the lumpectomy and radiotherapy. And you see the local recurrence is much higher in the lumpectomy. This is logical, because if you remove a small portion of the breast instead of a large portion, you have increased risk of the repetition of the tumor in the breast itself. Then we ask another question. Are you sure that radiotherapy is needed? So what to do? We organized a third clinical trial, comparing the classical breast conservation plus radiotherapy with breast conservation alone, a quadrantectomy without radiotherapy. And you see, again, if you don't apply radiotherapy, the increase of recurrence is very high. And so now we can conclude that this type, the original approach, which I presented in 1969, was the right one. Good breast conservation, good wide excision of the primary tumor, and radiotherapy. When I published my paper in 1981, as I mentioned, there was an increased number in the world of conservative surgery. And then when Bernie Fisher, 4 years later, published his own American data, which confirmed exactly what we started, you see the increased number in the world of the conservative surgery and the reduction of mastectomies. And today we can figure that some 300,000 women every year may save their breast thanks to these very pioneering studies in Italy and the United States. So I think this was a good success. And so the problem, the breast conservation, was solved. The second step, as I mentioned, is the conservation of axillary nodes. Axillary nodes have been for a century removed totally and always. It doesn't matter whether they were involved or totally healthy. They were removed, and this was something which we didn't like. So we started a new program with the sentinel node. Sentinel node biopsy. It's a sort of targeted surgery. Instead of removing all the lymph nodes, we remove only the one node. It's the first node which receives the lymph from the breast where the tumor is located. And we started a very large program in my institute using the radioisotopes, while Giuliano in the United States, they used the blue dye. There are two different procedures, but we had the same good results. And with these radioisotopes, with a little instrument here, a probe, a gamma probe, you may identify where the node is located and remove it. We remove the node, we make an immediate evaluation by histology of all nodes with 60 sections, while during the operation, and we immediately decide whether to proceed to this section or to stop there. We've done more than 15,000, not 1,500, 15,000 of this operation in the last 15 years, or 20 years now. Of course, as I said, all these advances are made by randomized trial. So we decided to randomize again 10 years ago, more than 10 years ago, this type of sentinel node biopsy comparing to the normal axillary dissection, the traditional axillary dissection. And now, after a number of years, after 10 years, you see the group who had the sentinel node removal only when it was negative did much better than the patients who had a total axillary dissection. This was a surprise in a certain way, since we expected to have the same survival, but we had 23 deaths in the axillary dissection against 15. So it's something which is very close to significance. And our immunologists, they believe that keeping good immunologically competent tissue in the axilla may be beneficial to the patient if it is not invaded, if it is not metastatic. Of course, we are following all our patients who had a negative sentinel node and had no axillary dissection. As you may know, some of you who are involved in breast cancer management, that when you do a sentinel node, in 6% of the cases, the sentinel node is a false, gives a false information. This is something we must know. The sentinel node is negative, but other nodes may be involved by cancer. And so we expect in these cases that metastasis in the axilla might appear. So in this large number of more than 3,000 patients, we expected, after 10 years, 213, 6% of cases. But surprisingly, only 31 appeared. Great difference. So this is not clear. So it means that if the pathologist identifies a metastasis in the lymph node, it's not necessary that this will proceed to an overt metastasis. It might disappear. So this is our opinion today after these studies. And what we have as an hypothesis is the cancer stem cells hypothesis. Who is familiar with the new researchers know that this is a new hypothesis which is very promising, also in terms of possible targets for new drugs. And this is the idea that if you have the cancer stem cells in the primary carcinoma, and they migrate, and the cancer cells migrate to the lymph node. But if the lymph node with the metastasis does not contain, the cancer stem cells will not progress to an overt metastasis. But if a cancer stem cells is there, will go on. You know, the cancer stem cells, they give, let's say, they give fuel to the proliferation of the cancer cells. Finally, the third area of development is the giving targeted radiotherapy to reduce the field of radiotherapy to a specific area Why? Because in our studies we discovered that the recurrences which appeared in breast cancer after breast conservation were all, I say all, limited to the area where the tumor was removed, where the scar area. They are all here, which is logical in a certain way. Why should be in another portion of the breast? Because, of course, some scattered cases of ipsilateral new tumors, because if you save a breast, of course, you have the risk to have new tumors in that breast like the other, the opposite one. So the question was, why should we irradiate all the breast and not concentrate our efforts in this area where the tumor was located and removed? So we decided to approach with a totally new idea this program or this problem, trying to irradiate a small portion during surgery, not after surgery for 2 weeks, 2 months like it is now. We decided to do radiotherapy immediately. And so we rediscovered the intraoperative radiotherapy, which was abandoned, nearly abandoned, because you have to transfer the patients from the surgical room to the radiotherapy room, which is a very unpleasant complication. But now this is over because there are mobile radiotherapy units which are available. We have a linear accelerator which come to the operating theater. This is a great thing, it's a great technological advance. And the mobile linear accelerator can be easily moved close to operating table. A robotic arm can take the correct positions for radiation, and appropriate mobile shields around and beneath the operating table guarantee correct radio protection. So this was really a great advance, which we started exactly 10 years ago, 1999. This new process, this new idea was totally new. Was only done by myself and my radiotherapist. At the beginning with some concern. It's a very simple type of approach. There are 5 different steps, which I show very quickly. This is a quadrant of the breast. Then you reconstruct the breast. Then you put 2 discs of lead and aluminum to protect the chest wall. And then you put the collimator, you see, and you do radiotherapy. This is the example. This is the mobile. Look at this beautiful machine. It's a mobile radiotherapy equipment. It's a linear accelerator. And you see the surgeon himself decides where to give the radiation. And we give a full dose, 21 gray, in 3 minutes instead of 2 months. In 3 minutes you give radiotherapy, which means in biological terms being equivalent to 55 grays in fractionated dosages. What are the advantages? First of all, the applicator is placed under direct visual control of the surgeon to the operating field. And radiation exposure of the lung and contralateral breast is dramatically reduced. But more important, the problem of the difficult access to radiotherapy centers is solved. You know that many women, they live far away from a radiotherapy center, at least in Italy, but I think also in the United States or everywhere. And if you have to go up and down every day to the radiotherapy center for 2 months, it's a problem. It's a problem for the people who have no means, who have no car, who have no money. So the poor people are condemned either not to have radiotherapy, which is a mistake, or ask the surgeon for a mastectomy, even for a tumor of 3 millimeters. So this was been for all my life an obsession, because it was unfair to the poor people. And so we decided to improve our own program just to save from sufferance an enormous quantity of poor women. So we started in 1999, and we have done more than 4,000 cases. 3,000 as a full dose, other in different conditions, which I don't. This is the review of the first 1,700 cases from 1999 to 2008, treated with a full dose. And surprisingly, again, the results were very good. We expected many unfavorable side effects, but nothing happened. We had very few severe fibrosis, which disappeared in 1 year. Some mild fibrosis, which are very of no importance. We had quite a number of liponecrosis, which is not a very serious problem, but may prolong the local local control of the operation for a few weeks, but very few anyway, 4%. The other one are normal complications for any surgery. But look at the results. We had only 2.6% of local recurrences, which is lower than the normal rate of recurrences we have in the normal quadrantectomy and radiotherapy. We had a small number of ipsilateral second breast carcinoma, very few distant metastases, 2%. And altogether, we lost of this 1,200 patients, only 15. We had only 15 women dying for breast cancer, which is less than 1%. So for the moment, we are very satisfied. But as I said, we have the principle, absolute principle, scientific principle to randomize patients. So we randomized more than 1,300 patients, breast conservation surgery and breast conservation and conventional radiotherapy in 2 months, breast conserving surgery and ELIOT, electron intraoperative therapy, 21 gray. Of course, this has been closed recently. We'll need another couple of years to have the results. Then we use also radiotherapy, intraoperative radiotherapy in young women to give the dosage in a limited, to give radiotherapy to the limited dosage, 12 gray, and the remaining quantity of radiotherapy given to all the breast in 2 weeks. Why so? Because in young women, more frequently, the tumor may be multifocal, maybe in different portions of the breast. And so we thought reasonable in these women, this subset of patients, to treat them also with radiotherapy to all the breast. The advantage is that it's very quick type of procedure altogether, and in 30 days everything is finished. Surgery and the boost the first day, then you give accelerated external radiotherapy for 2 weeks, and so you may start at day 30 systemic treatments, chemotherapy if needed, which is one of the problems we have, whether we prefer to have first chemotherapy and then radiotherapy, or first radiotherapy and then chemo. This was the program. Now just a few words about the new progress for the future. We are looking into more targeted, mini-invasive treatments, thanks to the education of women and the new equipment. We have smaller and smaller tumor in our institutes. And so we need more limited type of treatment, high intensity, focalized ultrasound, hadron therapy with light ions, avidin biotin plus radionuclides. They're all very interesting approaches of research, of course, clinical research. This is a machine which was donated to myself by Chongqing in China, and we started 1 year ago to do this type of treatment with high-intensity focused ultrasound. So the ultrasounds have never been used for treatment. They're used for diagnosis. But now this machine, we are able to concentrate the ultrasound from different sources into a single small spot, producing the destruction, total destruction of the tumor. So this is very interesting. This is one case. Before IFU and after IFU, you see the fibrosis. Then I mentioned hadron therapy. This is a very complicated type of treatment, very expensive, but very promising. We give new types of radiation of very high energy, and this might solve many problems. And finally, the intraoperative use of avidin. Avidin and biotin are two molecules which have a great affinity. They ask one to the other. They go close to the other as soon as they enter the organism. So we put a local avidin during surgery, and the day after we introduce biotin labeled with a radioactive element, which will take radioactivity on the spot where we put avidin. And this is very simple. You see, we put avidin after removing of the tumor in the tissues around. We have a special instrument. And when you put the biotin the day after by intravenous, all biotin, radioactive biotin goes in the position where we put avidin. So it's a very simple way to find the target for nuclear medical doctors with their instrument. A few words about the psychological impact of the patients. The patient's vision of the disease. I receive every day tens of letters from the patients. And this patient wrote that when he read carcinoma, it came as a terrible shock. Carcinoma is still, at least in Europe, I don't know in the United States, but still a frightening name. Women are terrorized when they read carcinoma because the old history of this disease comes to their mind. And how can we reduce the women's anxiety? First of all, with the preservation of the body image, of course. The second, with the dialogue. But we are facing also the problem of terminology to reduce the anxiety of the women. What do we mean? We mean that, for instance, we are now changing our TNM system. Because today, if you have an in situ carcinoma, which is not invasive, it is a benign type of proliferation, benign, 100% cure. Still, we use a very obsolete and old definition of lobular carcinoma in situ, which terrorized women. Women when they read carcinoma, they are really terrorized. Both for lobular or ductal carcinoma in situ, DCIS. So we're now proposing a new definition. Lobular intraepithelial neoplasia, ductal intraepithelial neoplasia, LIN and DIN, very simple type of names, and which are very well accepted. And they've been in American origin, was Hagensen, first many years ago to decide with these new names. What happened? What is the advantage? When you remove the term carcinoma for the in situ lesion, because carcinoma by definition is infiltrating disease, the addition of the term infiltrating to the other carcinoma is no longer needed, because we generally divide these tumors in the breast, intraepithelial, intraductal, let's say, non-invasive, and all the other carcinomas are invasive. But to differentiate, we really explain that this tumor was infiltrating. Now, if we don't talk anymore of carcinoma in situ, but only ductal carcinoma, ductal intraepithelial tumors, the name invasive is no more needed. Infiltrating no more needed. Because again, it's a terrorizing name. If the carcinoma is infiltrating, it means that it will reach all the organs of my body. But this is not true. The small tumors, they don't reach any organ. And so we are, in a certain way, misleading women in a bad way. We are making them thinking that are much more grave than the reality. So the idea is to have lobular infiltrating carcinoma cancelling the infiltrate, because carcinoma by definition is infiltrating. When you have a cancer of the lung, you don't say infiltrating cancer of the lung, it's cancer of the lung, or carcinoma of the kidney, or carcinoma of the thyroid. Because carcinoma implies, by definition, that it's infiltrating. So why to add infiltrating, which is an addition which may terrorize women? So this just to tell you how can we proceed, improve our attention towards the women's sensitivity. A few words more about the endocrine biomolecular treatments. I don't have much to say, just only to say that we have today now many targets here for new drugs. But they're improving. Every day we have more and more. And this is the future of our treatments. And again, one of the markers might be, I mentioned before, the cancer stem cells may be an important goal to be reached. If we can identify the cancer stem cell, if we can destroy the cancer stem cells, all the proliferation of the tumor will disappear. So maybe one of the possible solutions. Of course, there are many biological, biomolecular approaches, which you see here. There are 10 different approaches, or even more, of course. And some of them, like already in clinical studies, in phase 1 or phase 2. And so we think that the basic research will one day solve the cancer problem. We have many possibilities, many roads to follow. What is important to know that mortality for breast cancer is going down, at least in Europe, I know also in the United States, is going down with a continuous, regular type of curve here. And so this is something which is very encouraging. It means that all our approach, breast conservation, more human approach to the women is important. It's making the women more confident on the medical profession, making the women more motivated for early detection, because they know the early detection will save not only their life, but also their breast, which is an important component. So this this was my last slide. Just a few comments on what I said. You understood that certainly I devoted all my life to the, let's say, on the part of the women, trying to save from the aggressiveness of the surgeons, of the radiotherapists, of the medical doctors, trying to save their body image, save their, let's say, dignity of women. But all this made a lot of problems to myself. As soon as I proposed a new approach, I had very great hostility from the medical profession, from surgeons. When I proposed the quadrantectomy, was a reaction everywhere in the world. Somebody thought I was a quack. It was difficult to enter some surgical circles, even to step into important prestigious institutes. So it was a very difficult time for me, very difficult moment, because mastectomy was a dogma, as I said. It was impossible to think that something else could be a substitute to the mastectomy. And in general, new ideas very often are not easily accepted. And people have difficulty to reconsider the old concepts. So it was a difficult moment, but I was not discouraged, because many of you know that I had, in my long life, a number of different battles. I belong to the generation who was in the war. And at the age of 17, I was in the war. And unfortunately, a few months later, I stepped on a landmine which burst, which made me nearly dying. I spent months in a hospital with plenty of operation to remove all my fragments in my body of the mine. One of this is still there. You see, in my abdomen, this is a big piece of metal I have in my body, which makes me always problems with the airport metal detectors. And then I joined the resistance. I joined the resistance, the anti-fascist, anti-Nazist resistance, and I became a partisan on the mountains, and with, again, very difficult moments. And I escaped just for a few minutes, a firing squad. And after the war, I married a woman who is one of the survivors of the Holocaust, of the Shoah. Again, she spent years in a concentration camp in Belsen, close to Anne Frank. So it's, all segments of a very difficult life, adventurous life. As soon as we married, we wanted just a baby girl, a little girl, because we like women. I would like to. But 4 boys arrived, one after the others. And fortunately, 2 little girls arrived later. You see there. And again, another boy later on. So it's a big family. We have, as was already said, 7 children, 15 grandchildren. We have a very big community in Milan, very compact in principles, in moral issues. Also, the pleasure to be in a great company. I received many prizes, many awards in my life, including 10 honorary degrees from many universities all over the world. And, but I must say that today's prize is especially important for me. I'm very honored because it's a very important story behind, as you heard by Mauro. And then we have another, I received another award a few years ago, which made me happy because a group of women in Rome, in a women movement, they decided to give me this type of honors. Honorary woman. Thank you for your attention.
And as you're all standing, thank you so much. Can I ask my children to come up, Giacomo, Kim, Chiara, Ilaria, Federica, for the presentation of the award? You've already gotten so many awards, you're already a honorary woman. So this is a small token of our appreciation for everything you've done. And let's stand here so the camera can roll. Kiddos, you come here. Okay. Would you like to present the award to Professor Veronesi? Thank you. Together with that, we have a little bag of goodies. Where is the bag of goodies? Here we go. With mementos of our Ohio State University. This comes complete with hats. It comes complete with all sorts of different gifts that hopefully will help you remember the greatness of this institution. So, Umberto, that was unbelievable. Thank you so much.